Yeah. HP. That's what we're about.
Does anybody want to work in neonatal ICU after graduating?
I would have to experience it first.
Yeah. I need to see it.
Yeah, I need to experience it before I can judge that one.
That's amazing.
I worked with one of babies.
Cause I think I wanna do a lot of things and then I do it and then I don't, so I need to see. proof.
I see, okay.
Is it like hard, like, I guess, is it competitive? Do a lot of people want to get in, or is it?
There's a severe shortage of neonatal respiratory therapists.
Really?
No,
They have extra credentials you can get for that.
yes. Yeah, so you can be NPS, neonatal pediatric specialist. It's another exam that you have to take. But you could graduate, get registered, turn around and apply for your NPS credential, take that test, and then be RRT NPS.
Do you think the Broad College curriculum, I guess, prepares us for that? Oh,
Yes.
nice.
Don't they get paid a little more?
Yeah, I thought when you get a little extra credential tacked on there, you get a little.
That would be a good question to ask when they come today to talk to you. So if you get extra credentials, that moves you up the career ladder. Does that mean you get extra pay? Yeah, that would be good to know.
Most therapists say no,
Oh, really?
I got some, they'll say not really, but it's good to have. The extra
Wow.
credentials,
But it
but
gives
you
you
should get paid
more
more because,
Choice.
you know, they cost money, so I don't know.
I
That could change.
If you do it, you need pals.
It helps.
probably.
Yeah, a lot of what you learn during the PALS course is on the NPS exam. So yes, that would be a big help.
Have pals and have the best friend that's support.
Are you interested in neonatal pediatric respiratory care? Oh. But you have it just in case.
You have to have it for,
Oh, I see.
having to work in these two.
Ah, okay. All right, great. Okay, so a fetus is a human being in utero. So an unborn baby we call a fetus. And for the first 8 weeks of existence, it's called an embryo. The first 8 weeks after the egg is fertilized. It takes 40 weeks from conception to birth. So I've always heard, oh, pregnancy is 9 months. No, it's 10 months. So 40 weeks. So I want you to write down some notes with this. The word gestation, I'll put it in the chat. Gestation is the time since conception. And normally it takes 37 to 40 weeks for the fetus to develop into a newborn. So 37 to 40 weeks. I wrote down 37 to 40 weeks is the normal time for a full-term birth. And if the baby is born before 37 weeks, they're considered a premature. So less than 37 weeks is considered a premature delivery. So when the baby is born, they call that a delivery. So if a baby is born and they are, let's say 28 weeks, it's been 28 weeks since they were conceived and now they're born at 28 weeks. They'll continue to keep track of their gestational age even after delivery. Just so that you realize the development that's going on, because if a baby is born in June and they were supposed to be born in August, when they're 2 months old, you would think, okay, at 2 months old, they should be able to turn their head or lift their head up. Well, wait a minute, they're not really 2 months old. They were born prematurely, so they're not going to have the same development as a full-term baby that was born at 40 weeks and is 2 months old. So that's why they keep track of the gestational age, the amount of weight for a premature baby that's 2 months old is going to be different than a full-term that's 2 months old. So when do we use the term neonate or infant or pediatric? So a neonate is considered the first month of life. An infant is 1 month up to 1 year. And a pediatric is up to 16 years.
Question.
Okay.
What is perinatal? I've heard them say that in the hospital.
Around, peri is around the time of delivery.
So like immediately after birth or no?
Not necessarily. So if they're saying, what is perinatal care for this 28-week premature baby? So now that they've been delivered, how do we want to care for them? So perinatal care could be referring to mom and what to do with mom before delivery. So around the time of delivery, I guess. So if you're working in pediatric ICU, you're going to be working with newborns up to 16 and sometimes even older. Especially kids with cancer, they like to stay with their same pediatrician. So even if they're 17 years old and they get admitted to the hospital, they want to go to pediatric ICU so they can have their physician caring for them. So sometimes you get even older kids than 16 in the pediatric ICU. So the neonatal ICU, they have really stringent standards as far as what can come into the unit. So a baby that's born hasn't been colonized with the bacteria from an outside environment. So if there's complications, they go from labor and delivery, they're brought into the neonatal ICU. But let's say the baby's born, they're doing great. And day 1 or day 2, there's a problem. And the parents bring the baby into the ER. Does the baby go to neonatal ICU? And the answer is no. Because once they leave the hospital, now they're considered colonized with outside bacteria. Now they go to pediatric ICU. So if you're working pediatric ICU, you're taking care of many different types of patient populations, from newborns, pediatrics, all the way up to adult-sized kids that you put on the ventilator. So I think that's like the most challenging area of the hospital to work, especially now with the technology, having heart transplants, and you've got the therapists involved in that. If you're interested in the ECMO team, you've got that kind of technology to use at the bedside. There's a lot.
Okay, so the difference between NICU and PICU is that the children in PICU, they've left the hospital, whereas NICU, they haven't left the facility.
Yes.
Okay.
Yes, so NICU is only babies that haven't left the facility. They do transport from one NICU to another NICU though.
Right.
And then after they're in NICU for a couple months, then they'll transfer them up to pediatric ICU also. Okay, and then there's different levels of neonatal ICUs. So for level 1, that's like the lowest technology driven care, I guess you would say. They care for healthy full-term newborns. So level 1 is healthy full-term newborns. Level 2 NICU can care for 32 weeks premature babies. So 32 weeks for level 2. Level 2 can provide oxygen therapy, nasal CPAP, and some mechanical ventilation. So O2, level 2 is 32 weeks and older. Yeah. So they don't have like high frequency ventilators or they don't have ECMO. That's reserved for level 3 NICU. So level 3 has 24-hour-a-day surgeons, intensivists, and they provide ECMO. You probably heard about ECMO already. I'm throwing the term around like you guys are familiar with it. But you have heard of it. It's taking blood outside the body, oxygenating it, getting rid of the CO2, and then putting the blood back into the body. Usually the major veins are cannulated, so they can take a large amount of blood out at a time, put a large amount back. So in a level 3 NICU provides ECMO, high frequency oscillation for mechanical ventilation, jet ventilation. I know that Joe DiMaggio Children's Hospital next to Memorial is a level 3. I'm not sure about Broward Health being level 3. I don't think they offer ECMO. I know they were talking about getting an ECMO team there. Do you guys know if they're doing ECMO at Broward? You don't think so? So that would make them level 2 NICU. Okay, so we'll stop here, take a break. All right, so when a fetus is in utero, obviously it needs to get nutrients, it needs to get rid of waste, it needs oxygen, it needs to get rid of CO2. And how does all of this happen? Well, what grows in the uterus is called a placenta. And what the placenta does is it allows mom's blood circulation to meet up with fetal circulation. So blood vessels from the fetus will grow into it, and blood vessels from mom will grow into it. And that's where everything crosses over from mother's blood to fetal blood and vice versa. The circulatory systems are considered completely separate. So even though they're close to each other and they match up, it's 2 separate circulations that are meeting. And then at the bottom, it says abnormal implantation of the placenta on the uterine wall. And I have some notes for you to write down. In this picture, you see how the placenta is located towards the top of the uterus. And then vagina, birth canal down here. So this is normally where the placenta should implant and start growing. Sometimes it grows over the cervix. So that's a problem because how can the baby be born if the placenta is in the way? Or what if the placenta separates from the uterine wall and now you don't have circulation go into the fetus? So different things can go wrong. Let's see. So the first one is IUGR. It's too small to see. IUGR is the abbreviation, and it stands for intrauterine growth retardation of the fetus. So if there's not enough blood supply coming into the placenta, then the fetus is not going to grow in size normally. And when it's born, it'll be smaller than normal. So it's because the placenta is not delivering the nutrients that the fetus needs. IUGR, intrauterine growth retardation, the fetus. The second note I have is that if the placenta implants abnormally, it can cause fetal asphyxia. No. So problems with how the placenta is attached to the uterine wall can lead to fetal asphyxia. Can you figure out why you would have lack of oxygen going to the fetus if there's a problem with the placenta? Perfect, yes. If you don't have good circulation from the mom going to the fetus, then there's not going to be oxygen delivered to the fetus. And the next one is called placenta previa. Placenta previa. The placenta covers the cervical opening. And then if the placenta separates from the uterine wall, it's called placenta abruptio. Placenta abruptio is the placenta ruptures and separates from the uterine wall. So again, if it does that, now you don't have the same amount of blood vessels coming from mom and going to the fetus. That's it. Yeah, just if you hear that something can happen to the placenta, how does it cause problems with the fetus? That's pretty much all you need to know. Okay. This is an artist's drawing showing the placenta. So you have mom's arteries growing in the placenta and then fetal circulation growing into the placenta. And these little blood vessels are called chorionic villi. You type it in. Ooh, how do we spell that? Chorionic villi, V-I-L-L-I. So chorionic villi are fetal blood vessels in the placenta. So fetal blood vessels in the placenta. No, I don't know how to sign in.
Watch it at home.
Let me just try my. I don't have a password. Nope, I don't know my password. All right, so it shows, when you watch it at home, it just shows the placenta in real life, and it's huge. It supposedly weighs 1 pound, but it looks like it weighs 5 pounds. It's a massive human flesh. Looks like the liver. So there's a lot of surface area for the two circulations to meet. All right, so the blood vessels in the placenta are connected to the umbilical cord, which is connected to the fetus. With the umbilical cord, there are 2 arteries. So if you do, pardon me. If you could see a cross section of the umbilical cord, you're going to see 3 vessels. 2 of those vessels are arteries. The arteries branch off of the femoral artery. It's called the internal iliac artery. I can put it in the chat. And then that supplies the umbilical cord and goes to the placenta. So it says 2 umbilical arteries bring deoxygenated blood to the placenta, and then 1 fetal vein carries oxygenated blood back to the fetus. So remember how anything that's away from the heart is considered an artery. Anything going towards the heart is considered a vein. So here we've got the arteries having deoxygenated blood and the vein carrying the oxygenated blood from the mom back to the fetus. So I just wrote down that the umbilical arteries branch from the internal iliac artery. That's not a test question, by the way, but in case you wanted to know. The mother's PaO2 is, so what's a normal PaO2 for adults? Okay, very good. So 80 to 100, what are the units? Yes. And normal fetal PaO2 is 32 torr. or millimeters mercury. 32 torr. So an entire human being develops with a PaO2 of 32 torr. I find that amazing. What's also amazing is after the baby is born, we think, oh my gosh, we better get their oxygen level up, but they're used to having a PaO2 of 32 torr. So the amount of oxygen in newborns is less than what it is for the adults.
What was it? I'm sorry, what was the name of the fetal?
The amount of oxygen in arterial fetal blood is 32 torr. So if you're able to go into the womb, get a blood gas, put the blood into the machine, it would say 32 torr. Fetal hemoglobin has a higher affinity for oxygen. So oxygen will stay on the hemoglobin more so than with adult hemoglobin. So what this does is causes a higher saturation at a lower O2. And it gives you an example. For fetal hemoglobin, if the PaO2 is 30, we look at the saturation at 75%. But if an adult has a PaO2 of 30 and we look at the hemoglobin saturation at 60%. So you see how fetal hemoglobin hangs on more tightly to the oxygen? So if the oxygen is holding on to the hemoglobin more tightly, which way does the oxyhemoglobin curve shift? Does it shift to the left or does it shift to the right?
So the right is less affinity for oxygen, so.
Very good. Okay, so it shifts it to the left. Stronger affinity, shift to the left. And then for a pulse ox reading, it's the same wavelength of light as adult hemoglobin. So if you were to take, let's say your short pulse oximeters, and you take a pulse oximeter from adult ICU, you disinfect it and you take it over to the neonatal ICU and you put a sensor on the infant's finger, will it read correctly? And the answer is yes. So it's the same wavelength of light absorption with neonatal hemoglobin compared to adult hemoglobin. Same wavelength of absorption between neonatal hemoglobin and adult hemoglobin. So the pulse oximeters work the same. So fetal hemoglobin is a little bit different in its structure. So when the baby's born, and now we always have red blood cells that as they get old, our spleen will filter them out of circulation, and then we produce new red blood cells. And typically that's 90 days is the life of a red blood cell. So same thing with when a baby is born and they have this strong affinity for oxygen. Well, those red blood cells only last about 3 months, and then they're taken out, and then regular adult hemoglobin is produced. So by, what did I write down? 4 months of age. So by 4 months of age, neonatal hemoglobin is no longer produced. It's adult hemoglobin that they make. This is showing the oxyhemoglobin dissociation curve and looking at the saturation of the hemoglobin, comparing it to the amount of oxygen dissolved in the plasma. With a PaO2 of 30, we see that adult hemoglobin has less of an affinity, less saturation compared to fetal hemoglobin. Pardon me. Right, so when you're working in neonatal ICU and a baby is born prematurely, how prematurely can they be born and still sustain life? So obviously all of the organs are still developing, and can it support life? And what it comes down to is now with current technology, around 22 to 24 weeks of age, a newborn can still be viable. So how many months of pregnancy is that?
Like 6 months.
Yeah, so 6 months of pregnancy, they can't stop labor, the baby's born, can it survive? So there's an increased amount of statistics that show they can't survive after 24 weeks. So the problem with the lungs is you've got the lungs developing, it starts with the conducting airways, and then you get the alveolar sacs, and finally the alveoli develop. Then you've got your pulmonary circulation. You get your major vessels and then the smaller vessels that go across the alveoli. Those are developing. At 24 weeks, there's so much space between the circulation and the air sacs that it's really hard for oxygen to get across and for the lungs to support life. So they may end up, usually they have to be given surfactant into the lungs to help develop the surfactant. No, I didn't say that right. They have to be given surfactant in order to keep the alveoli open, and they need positive pressure to help oxygenate. So with that, either CPAP or on mechanical ventilation, then you can't support life that way. So in order to understand 22 to 24 weeks, I just go through the different stages of lung development. One of the criteria for ECMO is it has to be full term. I think because the blood vessels are too fragile to support ECMO. Yeah, why couldn't they just hook the umbilical cord up to an ECMO machine,
Yeah. That's not-
instead of having to cannulate vessels? Cut the umbilical cord, hook it up to the ECMO machine, and yeah, it's a good idea, but I don't think it's been done yet. The first 8 weeks of, whoops. The first 8 weeks of development are called the embryonic stage. So the first 8 weeks of gestation is called embryonic stage. And it starts off with this lung bud, and it branches off and develops into the trachea and then the right and left mainstem bronchus. So within 8 weeks, you've got a trachea and the right and left mainstem bronchus. The next stage of development is the pseudoglandular stage, and it got its name because the lung looks like a gland. And this occurs 7 to 17 weeks. and you get conducting airways. Okay. So this is all this picture is showing what you get after 8 weeks. So there's a separation where you get an esophagus forming and a trachea forming. And then from the trachea, you get your right main stem bronchi. And then the pseudoglandular period, this one says 6 to 16 weeks, and it depends on what textbook you're reading. So the 7 to 17 weeks comes from the current textbook. It's arbitrary, doesn't make a difference. So the pseudoglandular period, you start getting your conducting airways. So all you had was your right and left main stem bronchus, and now you're going to get the lobes. So your bronchi and bronchioles start to form. So bronchioles, still not good enough, right? So if you're born at 16 weeks, can we give you some nasal CPAP and surfactant to support life? And the answer is no. And then stage 3 is called canalicular. So you're getting your airways and pulmonary vasculature formed. Alveolar epithelium differentiates into type 1 and type 2 cells. Do you remember what those are? Type 1, type 2?
Type 1, that's just the cells, just the tissue, and type 2 is the surfactant producing stuff.
Yeah, so the alveolar cells are made up of type 1 cells, and then the type 2 stores the surfactant in the little lamellar bodies. It says the air to blood barrier is thin enough for gas exchange, but true alveoli have not formed. So I want you to write down any notes on this. Maybe a sinus is developing. I don't think that's on there. So I wrote the sinus is developing. So that's your alveolar sacs, and then your clumps of alveoli form. Immature surfactant is forming. So it says that surfactant is being stored in the lamellar bodies, but at this point in time, the surfactant has not matured. And then at the end of the stage, survival of the fetus becomes possible. So I'll write that down. Survival of the fetus becomes possible if they're born prematurely, between 22 and 24 weeks of gestation. Yeah, it would be interesting to see statistics on what the problems are when a 24 or 22 weeker, you get them through, they live, do they have problems with development? What about neurocognitive skills? Is that normal? So just because they're born and we can keep them alive, I'm sure they have a lot of problems that they wouldn't have if they were born at full gestational age.
Does parents have a say in that? Like, if the baby's born really premature, and they say,
we can try to keep them alive, but they'll be severely, mentally, neurologically disabled, and the parents say like, I don't want them to live that way, or.
Yeah, I don't know what the cutoff is for the parents to be able to say that, but yes. Yeah, definitely. Okay, the saccular stage is 27 to 36 weeks. And the alveolar sacs continue to develop. Oh, it already says that on the PowerPoint. And the alveolar stage, alveoli continue to develop. So that's 37 weeks to term. When a full-term baby is born, they have 50 million alveoli. How many alveoli does an adult have? Do you know, Tijan? Yeah. Is that what you said, Taylor?
I was gonna say 250.
You're pretty close. So how do we get from 50 million to 300 million? At 8 years of age is when they finally have all 300 million alveoli. So 50 million at birth, and by 8 years of age, 300 million. Okay, and then it summarizes, it says, surfactant is secreted into the alveoli beginning at 28 weeks up to 38 weeks. So why this is important to you is if you get a premature baby born at 28 weeks, you're working in neonatal ICU, there's a good chance that their surfactant is already mature enough to keep the alveoli open. They might need a little bit of nasal CPAP, a little bit of positive pressure, maybe a little bit of oxygen, or they could be on room air and need nothing at all. Sometimes, if it looks like mom's going to go into labor prematurely, they'll give mom steroids, give her glucocorticoids. Those steroids get absorbed by the fetus, and it causes the surfactant to develop like within 24 hours. It goes from an immature surfactant to mature surfactant. So if they see that mom's going to go into labor and there's nothing they can do about it, they'll go ahead and give steroids to mom to try to get that surfactant to mature, so the baby won't need oxygen or surfactant once they're born. And it says less than 28 weeks, little or no surfactant is present, and it varies. So it'll depend if mom had steroids, it just depends on the newborn. So you would think, okay, less than 28 weeks, baby's born, let's intubate them and push the surfactant in. And that's not the case. They will wait to see if they need to give surfactant. So an increased amount of oxygen being needed to keep their SATs in range, then they'll say, okay, yes, we need to give surfactant. Or you see a lot of grunting and increased work of breathing because all the alveoli are collapsing. Okay, yeah, we need to give surfactant. But they don't automatically give it because of the prematurity, which always boggled my mind. But yeah, they do it on a case-by-case basis. All right, but for testing purposes or for working in neonatal ICU, to remember that 28 weeks and more, most likely they'll need no oxygen and no positive pressure, or they might need some. This shows these big blank spaces are alveoli, and you can see the small pulmonary capillaries going past the alveoli. I don't know why I've got this here, but it shows how thin the membrane is, and oxygen and CO2 can easily get back and forth. So as the lungs are developing, I gave you, for the embryonic stage up to 8 weeks, and then the pseudoglandular stage, they kind of overlap each other a little bit. So I don't know, just review the numbers that I gave you and know that sometimes it can be a week different depending on what book you're reading. Yes. 17 to 26 weeks. Did I put it here? I guess I didn't put it, did I?
I didn't know.
You had to do the math. You're so kind. Well, thank you for asking, Marlon.
17 to what?
26. So that was the canalicular stage. Okay, and then there was something else I need to tell you. The lungs are filled with fluid beginning with this stage of development. So in utero, if you were to see like a moving video of a fetus in utero, you'll notice that their chest goes in and out like they're breathing. But they're not breathing in air and exhaling air. There's fluid throughout all of the conducting airways and in the alveoli. So it's just moving this fluid back and forth. It strengthens their muscles so that when they are born, they do have muscles developed for breathing. But it doesn't serve a purpose. So they're not breathing in air and exhaling air.
When does that occur again?
During the canalicular stage.
Doesn't that occur all the way till birth?
Yes. Yeah. So at birth, their lungs are fluid filled, and this fluid has to be evacuated in order for them to start breathing air. And usually that happens as they're going through the birth canal. It kind of squeezes their chest a lot. A lot of fluid will come out that way. And then when they take a deep breath in, it'll bring air into their conducting airways. And eventually whatever fluid is left gets absorbed into the lymph system. So we talked about how the lungs are filled with fluid. The fetus is also surrounded by a layer of fluid called amniotic fluid. So this fluid that surrounds the fetus is sterile. All right, so the gestational age of the fetus, it wants you to fill in how many weeks a full term is. Do you know what to put in for that? 37 to 40 weeks. And preterm? Yes, less than 37.
But they're moving forward if they go beyond the 40 weeks, or would they always do a forced birth?
Yeah, they schedule the delivery and they induce labor. Amniotic fluid is secreted and reabsorbed by cells lining the amniotic sac at a rate of 500 mLs per hour. So it's not just a stagnant fluid. The amniotic sac secretes fluid, reabsorbs it. Got that? So how can we tell if the fetus is doing okay, if there's nothing detrimental happening to the fetus? One way is by using ultrasound to take a look at the fetus, see if it's moving around. So for a fetus to not be moving, to be holding completely still is unusual. There's usually a lot of movement. And do I have another thing ultrasound does is it can take measurements and decide if the fetus is the right size for their gestational age. All right, so it doesn't talk to you about the biophysical profile, so I'll put it in the chat. So this is done with ultrasound, and there's some 5 things that they're looking for. So biophysical profile. Amount of, what's the first one? They're looking for fetal breathing movements is number 1. I described that already, right? Even though the chest is moving in and out, it's just liquid going in and out. There's no gas exchange taking place. But there should be breathing movements. The next one is gross body movements. By the word gross, do you know what that means? It doesn't mean disgusting.
Like total?
Large muscles. So gross body movements would be the arms and the legs moving. I guess gross versus fine. Like if your fingers are moving, that's fine muscle movement. Gross muscle movement is big muscles. Third one is fetal muscle tone. Fetal muscle tone. So if they're limp and not moving, that's a bad sign. They should be moving around. Next is amniotic fluid volume. Oh, I stopped numbering them. 1, 2, 3. This is number 4. amniotic fluid volume. Having too much is called polyhydramnios and affects brain development. Should I put that in the chat? Polyhydramnios. Polyhydramnios is too much amniotic fluid and it causes brain damage. And then too little fluid is called oligohydramnios. Oligohydramnios, not enough amniotic fluid. And then number 5, they're looking to do a non-stress test. What is a non-stress test? They're looking for fetal movements with the heart rate going up and down.
If too much fluid, you said it can cause brain damage, but not enough fluid, is that the same?
No, I don't have that. Not enough causes brain damage. For not enough, I just have it influences lung development.
Influences on it, so it helps.
No, for oligohydramnios, if there's not enough amniotic fluid, it can slow down lung growth. So let me explain the non-stress test. I was mentioning how there should be fetal movement, and that's normal. And as a fetus moves around, its heart rate should increase. But when it holds still, then the heart rate should come back down again. So having the heart rate go up and down is very normal. If the heart rate is the same all the time and it never changes, that's a bad sign that there's something going wrong. So you're looking for the heart rate to increase and decrease. And if it's not, there's something wrong. Maybe the fetus isn't getting enough blood flow. So that's a non-stress test. And then a stress test would be where they give mom a medication to make the uterus contract to see if they can get the fetus to move around a little bit. So they call that a stress test, where they give so the fetal stress test, they give mom some Pitocin to see if the fetus starts to move around. Pitocin is a medicine that makes the uterus contract. I'm going to open that back door in case our visitors come. All right, so an amniocentesis is putting a needle through the abdominal wall into the uterus and taking some of the amniotic fluid and then running testing on the amniotic fluid. So it's kind of a risky procedure because once that needle goes in, now you've got a hole in the uterus and fluid can start leaking. Sometimes it can cause mom to go into premature labor. So it is kind of a risky procedure. It says they ultrasound first to avoid hitting the placenta. So they don't want to go into the placenta with the needle. So they do an ultrasound so that they can avoid the placenta. One of the tests performed on the amniotic fluid is genetic testing. So they're looking for trisomy 21. Do you know what that is? Down syndrome. Spina bifida, which is a neural tube defect. And find out the sex. But that's not good. Just gonna do it one more time. All right, so I wrote down some of the things that they look for on the amniotic fluid. So trisomy 21, spina bifida, sex of the fetus, and cystic fibrosis. So when the testing is done, and if they find that there's like trisomy 21 or neural tube defects, the parents can be given the decision to stop the pregnancy. But now that it's up to the state, I don't know what they do anymore with counseling parents. I don't know, is abortion legal in Florida? No. So if they find out that the fetus has trisomy 21 and they want to not continue with the pregnancy, can they abort? So I guess not in Florida.
I think it's up to 24. Right.
Oh, okay.
Can you do it for certain medical emergencies? Or what if they have a topic?
It's fine for that as well.
Yeah, it's right now.
For medical purposes.
Oh, really?
There's only like 8 or 11 states or something like that. This state that we can see the abortion.
8 states?
8 or 11.
Wow. All right, so the next type of testing they do is they look to see if the lungs are mature. And one of the ways to see if surfactant has matured is to look for the components of surfactant. And 2 of the components, one of them is lecithin. And that's like a short abbreviation for its actual name, dipalmitoyl phosphatidylcholine. We'll just say lecithin. Sphingomyelin is another component of surfactant. So these components will be present in amniotic fluid, but it's the ratio of the 2 that indicates whether the lungs are mature. If you have twice as much lecithin than sphingomyelin, that tells you that the lungs are mature. If the ratio is less than 1, then the surfactant is not mature and the baby will need surfactant when they're born. Otherwise, they'd be at high risk of developing respiratory distress syndrome. Okay, and then, did you guys write down that moms are given glucocorticoids if they're going into premature labor? No, okay, so I'll put that in the chat now. So glucocorticoids are given to women in premature labor 48 hours before delivery. I wonder if they always have 48 hours to play with. Probably not. Or within 7 days. And then this will cause surfactant to mature. So this slide is showing how at different weeks of gestation, there's different amounts of lecithin and sphingomyelin. And at 28 weeks, there's definitely not a 2-to-1 ratio. So how babies are able to breathe without oxygen or positive pressure, I don't know. But come 35 weeks of gestation, now there's twice as much lecithin as sphingomyelin. So the alveoli will stay open because the surfactant is mature and it'll keep the alveoli open. There are other tests like in the neonatal pediatric respiratory care. Scott Jones, did you guys know about Scott? He used to be the clinical coordinator here. So he's writing this. He's always looking into all the articles, all the journals. So he updates things more so than the textbooks do. And he writes in here that the most common test to look for the surfactant being mature is called lamellar body count. Do you want to write that down? Lamellar, L-A-M-E-L-L-A-R, lamellar body count. Most common test for surfactant maturity. Most common test for surfactant maturity. And then write down greater than 50,000. Greater than 50,000. And the units are MCL. So I guess that's microliter. MCL. Greater than 50,000 would be yes, surfactant is mature. So that's 2 tests. We talked to the LS ratio, the lamellar bodies. Here's one that looks for phosphatidylglycerol. This is only present at 36 weeks of gestation. And it's popular because it's supposedly the most reliable indicator of pulmonary maturity. That's 1, 2, 3 tests. And then the 4th test is the shake test, where they take amniotic fluid, they mix it with different amounts of alcohol and they shake it up. And if there's bubbles that form, that tells you that yes, there's surfactant present. Oh, really? It was here. Well, we already wrote it down. So the heart forms by the 4th week of gestation. And it'll have its 4 chambers by the 4th week of gestation. And when you're listening to the heartbeat, a fetal heartbeat, a normal heart rate is 120 to 160 beats per minute. So it started off as a single chamber, and then it divides, and then you get the 4 chambers. Okay, they're not here. I'm going to keep going until they arrive. You guys okay with that? You still with me? Okay. Uterine contractions. So mom goes into labor, uterus starts contracting, and as the uterus contracts, of course, it's going to eventually push the fetus out, and then it'll be born. During labor, when the uterus is contracting, sometimes that contraction can like squish the fetal head, and it causes a vagal response, and then the heart rate slows down. Sometimes the contraction can stop the blood flowing to the placenta. That's not a good thing. So anyway, there's some belts wrapped around mom. They put 2 belts around mom's belly. And from that, they can measure how strong contractions are. So the muscle contractions, and then the second belt is picking up on fetal heart rate. So that's the background story to labor and looking at uterine contractions. Normally, the heart rate is not affected, or it will vary up and down from baseline heart rate. So if the heart rate decreases early in the contraction, this indicates, and then it gives you a blank spot, and you want to put in there head compression. So if the heart rate decreases early on during the contraction, this indicates head compression and vagal nerve stimulation, which is okay. So let's say that it's not dangerous. However, if the heart rate decreases late in the contraction, this indicates uteroplacental compression.
You just talk about a contraction with childbirth.
During labor, yeah. So heart rate, if it decreases late in the contraction, it indicates uteroplacental compression. So the placenta is being compressed, and it's going to stop blood flow going to the fetus. So this is a dangerous sign. because it compromises blood flow and O2 delivery to the fetus. Yes. Yeah, so what could you do? I mean, if you've got these belts on and you see that the fetus is not getting oxygen every time there's a contraction, that becomes a medical emergency. So they'd probably do a C-section, where they surgically cut mom to get the baby out. Under anesthesia, of course. You have this look on your face like, wait a minute.
Anesthesia.
What's that?
I said, I don't think they do it any other way.
Okay. All right, this is showing the two belts. So the belt at the top is showing uterine muscle contraction. The bottom one is showing the heart rate. Did I tell you backwards? I told you backwards. All right, so the top one is the heart rate and the bottom one is the uterine muscle contracting. So here the uterine muscle contracts, and then we look up to see if the heart rate decelerates after the contraction or during the contraction. They kind of line up, wouldn't you say? So is that bad? That's not bad, right? That's normal. That's just head compression. The vagal nerve stimulates the heart, and if you squeeze the head, then the vagal nerve, when it's compressed, it doesn't send a signal to the heart. This one kind of looks like it lines up too. Variable decelerations. All right, and here's one where you have your uterine contraction and you look up and you see that the heart rate decreases after the contraction. So this is what they call ominous. Have you ever heard of that word? Yep. Brent, have you ever heard of ominous?
Yes.
You have? I have been asked about this over and over during the years when you guys are taking the test. And every class will say, what is ominous? Because that's how the question reads on the test.
They not read.
So yeah, ominous means bad. So if you look at the sky and you say, oh my God, that's an ominous sky, it looks like you're going to get a really bad rainstorm. So at that point, if you realize that fetal oxygen delivery is being compromised and baby needs to have a C-section. Is it okay for the heart rate to stay the same all the time and not vary up and down? No. So make sure you get that right on the test. It says beat to beat variability is bad or good or whatever it says. And yes, you want it to have variability. You want the heart rate to be going up and down. If it stays the same all the time, that indicates something bad. It sounds like they're here. So I give you guys a quick break. All right, we'll start here in the next time.